Now,
Boy,
you notice how the old people are wearing a jacket because I'm so old, and the young, vigorous people are in a T-shirt, and sort of middle here has got a long-sleeve designer shirt on his wife bought him.
No, I'm off today. I thought it was the Barbershop Quartet that we were doing today.
Okay,
so.
no, we're doing the Ask the Doctor show,
okay.
and BKP's the host.
Get at it, BK.
By the way, folks, thank you for being here. It's now time for Ask. There it is. That's the scenic railroad here in Blue Ridge. You can hear the bell in the background. You're going to hear the train whistle. It's Small Town America starting up in Blue Ridge, Georgia. I'm your host, BKP, Dr. William Whaley, Dr. Raymond Tidman. I have to share this with you. You got here just in time. I found out.
No.
I can't say it.
No, you can't.
I can?
My kids know. Yeah.
Do your kids know?
Yeah, they know.
This guy, 15 seconds before we go live, Dr. Raymond Tidman, we're talking about the 70s for some reason. He said he had an afro. Did you?
I did.
And a beard.
Afro and a beard.
Didn't shave or cut my hair for a year. It was my nickname was the Animal. So.
Well, let me ask you something. Did you paint Bob Ross too?
Oh yeah, I could have done that. I could have done that.
I had a burr haircut. I was in the military.
Clean cut.
I went to Vietnam, and I spent the next 9 years with the Marine unit. I looked like a shot off. I was so thin and buffed, it was amazing. I did physical fitness better than the privates. All right, you ready?
All right, no, I'm going to give you one thing. I'm giving you one thing while we've gone there. I'll never forget. I had the jean jacket, and I went upstairs and sewed the peace sign patch on my jean jacket. Now, wait a minute. I'm not done. Relax.
He's redeemed himself.
No, relax. Let me give you the story. So I'll never forget, I have the jean jacket, and because I was cool, very cool. And
thought you were anyway.
No, I was very cool. So I go upstairs and I sew the peace sign patch, right?
Yeah.
Now, the kitchen's right here, down the steps. In my house, if you could get down the steps and to the right really fast and get out that glass door without Dad seeing you, right? So when you were wearing something that you did not want Dad to see, down to the right, get out and I'll never forget. So I knew that peach sign, I'm going to get in trouble. Ran down those steps, took a right. Son?
Your left arm was in his vision.
Get back here. The end of the story is I did not get out that glass door, and my jean jacket did not have a peace sign on it. Moving right along.
All right, you
ready?
enjoyed
that story.
I did. That was a good story. I tell you, your left sleeve was in this field.
Yes, Dad.
My dad could see inside of his eyes, but wasn't wearing a hat. This program is supposed to be about medical stuff here. So
sorry.
we have got two really good questions today, and I'm going to tell you that the first question is really, if you look at it, it's a lot about me because I have had exactly what this patient's got, and I'm going to enlarge on it some. This is a kind of a PCP problem because it's very common in this part of the country. Some of you people live in Utah that are watching us, I know, but those of you that live around here can relate to this man. My father is 68 years old and in excellent health. He was raised on a boat in Florida. Maybe he didn't shave or cut his hair either. And has had numerous skin cancers frozen off and some biopsied and then removed. Last month, he had a relatively big squamous cell cancer taken off his forehead that was 1 inch across. That's important, the inch. He had Mohs surgery.
Now, in the old days, Bill, that was called being scalped.
Yeah, right. Exactly. I was going to show a picture of that, which I think I did a few weeks ago, but I'm not going to do it today. This time, the dermatologist did a gene decision test. Now, we've been talking about genetic tests on colon cancer, prostate cancer, and breast cancer to predict recurrence. Now, that's the next generation of these. These are brand new, and by the way, some of them haven't even been FDA approved, but Medicare is paying for one, and so it's working its way into the NCCN guidelines. But anyway, that test was done, and it said he had a 19% chance of metastasis in 3 years. Now, that's really important because a lot of the time we're going to be talking today about local recurrence in the site of the scar, but metastasis is going to mean it's spread somewhere. Now, you don't ever think here about regular squamous cell skin cancer being a metastatic disease. We're going to show you a picture in a minute where you see a malignant melanoma. So this time, at 3 years, and he is going to an oncologist next week. Why, and what do you think the oncologist will do? That's an interesting question, isn't it? And we've never heard a question like that before, except maybe about melanoma. All right, show that next one. This is about squamous cell cancer. The majority of the cancers that we have, this guy was raised on a boat. I went to work when I was 8.5 years old. In case you can't tell, I'm relatively blonde, and I've had 7 biopsies last year. 4 were malignant, and I was counting up the other day. I've had 1 melanoma, and I've had 26 different malignancies of the skin. Now, where she said they were frozen off, those weren't malignant, or at least the doctor didn't think they were malignant. That was this sun-damaged skin. I probably had 200 of those things frozen off. You still have that thing?
Yeah, I still got it.
Oh, he's got
Drop
one.
by sometime.
Yeah,
we'll spot welds.
Yeah, he's got one in his office where he can spot welds. Okay, take that one down. We're not going to do this education thing again, but frequently we have shown different kinds of pictures of skin cancers and then the warning signs of melanoma. But these are the common kinds. The one you got to worry about most of the time is the one in the upper left. That's the melanoma, and the one at the bottom right, Merkel cell carcinoma. We talked about that before. Take it down now. Okay, this here, it's a beautiful color picture. This thing on this man's forehead, I believe, is about an inch across. That's 2.5 centimeters to the inch for the engineers over there. So that inch is important, 2.5 centimeters. Frequently we talk about breast cancers being less than 2 or greater than 2 centimeters, colon cancers being 2, less than 2, greater than 2. We usually don't talk about skin cancers so much in their diameter, but that's important. So take that one down. If you look at this next picture here, that scar on that man's forehead is after Mohs surgery. I didn't show you the Mohs pictures. After it has been closed, it's above his right eye and on his forehead. My tumor that I had, about 2 years ago, you remember when my eyebrows were up here?
I actually do.
Okay, my eyebrow was up to here. Well, now I still pick eyelashes out of this part of my forehead every few weeks because the skin came down and what's left of the eyebrow there, and that scar's now all in a bunch of wrinkles. I got a lot of wrinkles. But that's what this surgery was done, and that's how that man looked on the operating table. Take that one down.
Bill, that's when the guy, I thought he was trying to make you look like Spock.
Yeah, he did. I did on this side for about 3 or 4 months. So I just put that next one up. We're going to look at it kind of quickly. But, we always talk about T. How big was the tumor? And that 2 centimeters in breast cancer gets you into stage 2, and the colon cancer gets you a little higher. Well, skin cancer, generally we talk about depth. But this is purely about size, and when you get to greater than 2 centimeters, which is this one was 2.5, he said it was an inch, you have reached a significant tumor size. That's called T2. Now pull that one down and bring up the next one. This is the Brigham and Women's staging system, and I did not get the history here of whether this had arisen in a site of one of those previous ones. But mine did arise in the site of a previous one. So it had recurred. We're going to look at recurrences in a minute versus metastasis. Well, these risk factors that you have here largely revolve around, just like in breast cancer, does it involve any nerve that you can see under the microscope? Does it go deeper than the skin and into the fat? You can pull that down now. But we do know from the fact that the dermatologist felt compelled to do that genetic test that they were sort of worried about the pathology. So throw this next one back up here. This one now looks at site of where this thing is. And it goes lip and ear and everywhere else. And it talks about rate of recurrences. But when you get to a point where you have had previous removal and everything is removed, or that it tends to be in and around the lips of the face, recurrence rates are up in the 25 or 30% range, meaning it's going to come back regardless of how much surgery they did. And then on the right-hand side here, you've got the metastasis percentage, and in some of these, in a scar, that's what mine was, and I think his was too. You can get up to 40% that will then go into lymph nodes or can ultimately cause death. So you can pull that one down now. So the question then is, the man has got a lot of bad skin. He was in the sun a lot down in Florida. I'm hoping that he sees his dermatologist every 3 to 6 months. It sounds to me like he's got a really good dermatologist. But when you have had more than 5 times that you have been blistered to the point of blistering in sun, you have put yourself in the category, even if you don't go in the sun again for the rest of your life, that you're at increased risk for all of this, particularly melanoma.
I used to do that 5 times a summer.
Me too. I used to work without a shirt. I was 8.5 years old without a shirt. I'd say 5 or more times every summer. So down here in the South, we're a long-term retirement fund for dermatologists, and I know that Ray and I both go to the guy and he freezes stuff off. Ray can freeze his own stuff off, I guess, if he.
And I do.
He can't see the back of his. He can't see his back, I guess. But anyway, I can't freeze mine off and don't want to. But I mean, when you have 7 biopsies in a year and 4 of them are malignant, you got to farm for malignancy. So what they're going to do with your dad it was his dad, right? Yeah. What they're going to do with him is he's going to an oncologist. That oncologist will probably image him. And he could do, and I looked this up very carefully, the NCCN guidelines really leave the imaging at this point sort of unestablished in terms of long-term benefit, but the guy's got great health. He's going to live another 30 or 40 years. He probably has good insurance. He's 68. So he will probably do some sort of an imaging. He might do an MRI or a CT or something. But more importantly, he's going to put him on the medical oncology follow-up list as well as going to the dermatology follow-up list, because a 19 to 30% chance of a metastatic disease is as higher than some of the breast cancers that we follow. So your dad's getting good care. The chances it's going to recur locally are probably about a third or greater. The metastasis, I think it said it was 19 or 20%. And they're going to try and guard against that, but there's you can't do with your dad like we do with breast cancer, colon cancer, and lung cancer, and that is give chemotherapy or immunotherapy before you start to prevent recurrence. There is nothing we can give your dad that would prevent recurrence. Now, is that sort of that's good?
Should I alert you? There's an old fellow looking at your old truck. I think he may want to buy it.
Well, he ain't buying it. He can't have it. And they take pictures there too, right?
Yeah. Hey, so let me do the primary care on this. Skin cancers for the medical students. You have ones that are discolored and ones that are rough. You feel. I've never seen a squamous cell cancer on somebody's butt. Have you?
No.
So it's a sun damage thing.
Yeah.
And
no, you mean you're talking about that wasn't a hippie out there in the beach?
Well, there could be. Yeah, our generation, there may be a few of those out there because they had some exposure issues.
Yeah, they did. Yeah.
So if you feel something, what I tell my patients and students is, if you feel something that's rough, it's flaky, then get your doctor to look at it.
And you can't see it.
You don't necessarily see it. You may feel it before you see it.
Right.
It could be an actinic keratosis, could be frozen off, could be gone. It's easy. So those are pretty straightforward. Don't ignore them, because they can be squamous cells and that can become deadly. And then the discolored lesions, which can happen anywhere on your body, even between your toes.
Oh yeah, it can happen where the sun doesn't shine too.
Yeah, that's what I'm saying. I was getting there. So those you look for some hallmarks. Is it getting bigger? Is the contour changing? Is the size changing? All those change issues, that needs to be seen. That you do not ignore, you do not wait on. A tiny mole that's changing, I call it a mole because it's a dark spot. Any dark changing colored thing with irregular edges that's growing, get that looked at as soon as possible.
Now, I'm going to tell you, I'm going to follow up on that. I've seen 2 melanoma patients this week in follow-up that had deep, locally advanced, node-positive melanomas that received immunotherapy. One was on the sole of the foot, and the other was on the scrotum. So those 2 areas were
Yeah.
non-sunburn.
Not an area that
Okay,
you
there's
see.
my melanoma scar. I have it on my forearm, one of those sunburns.
Yeah.
That big size, that big old scar. So he's right. If it doesn't feel right, it doesn't look right, go see your doctor.
Yeah.
Got it?
Got it.
How about that spot? No.
No.
You got something on your cheek there, right?
I
All right.
I have one on my shoulder. It's been there for years.
You want to take your shirt off for us?
Bring it in here. We'll
You don't want to see him with his shirt off. All right.
No,
My wife is 48 years old and had a small lump or something on her mammogram a year ago that was not seen on the mammogram the year before. So now we know this woman has had mammograms annually. 6 months ago, a follow-up mammogram was the same. So that means that they asked that she have a 6-month follow-up. And the report said repeat in 6 months. 4 weeks ago, the repeat was done. So she had a mammogram 2 years ago, a year ago, and 6 months ago following something. And then last month they did it again, and a small cancer was found in the breast almost to the armpit. And she had a lumpectomy and no lymph nodes. Now, you remember we were talking last week that you don't really want to do a mammogram in somebody that had a COVID vaccine because they could have a lymph node or something near the tail of the breast related to the
vaccination.
COVID vaccination. Well, that's not her issue because that was there a year ago and 6 months ago. But anyhow, that sort of brings up what we were talking about last week. All right, the cancer was less than 2 centimeters. Well, here we go again, size. And the surgeon, now listen to this, a surgeon, an oncologist, and a radiation therapist have been consulted. What does that tell you? She's in a cancer center and she's been presented to the tumor conference and she's seen everybody you could see. And they said she's triple positive, whatever that means. Now, we've talked about triple negative breast cancer a lot being so aggressive. This is the first time we've ever had a question about triple positive breast cancer, and I'll show you why that'll be in a minute. And she should have some sort of chemotherapy with an antibody and then a hormone tamoxifen and radiation. That seems like a lot of treatment for a small tumor with no lymph nodes. What do you think she should do? Now, what's the last thing say?
we have good insurance.
I hate the fact that that has to come into the question. I used to tell patients that if your wife wants to kill you and you're the husband, she can stab you, she can shoot you, she can poison you with arsenic, she can whop you over the head with a baseball bat, she can drag you out in the lawn and run over you with the car, or she could pour gasoline on you and burn you up.
And your point?
She could do all of them, and you'd really be dead. Show that next picture.
Seriously dead.
Seriously dead. Okay, so now here's the thoroughly dead. Well, we're coming back to that analogy in just a minute. Okay.
All right.
These are the different breast cancer subtypes. But when you look down here at the bottom, this triple positive is only 10% of
right.
breast cancers, okay? Triple negative, which is the baddie, is 13%. Well, it's not 50, but it's 75% are on the opposite side here. So the triple positive is, we hear about it all the time because it's so aggressive, it has to be so aggressively treated. And the triple positive, which is even less than that, is so easy to treat. So pull that one down and then let's go to the next one. Now this pretty picture here, big old thing, all this stuff here, this shows all the different ways you can treat cancer. You can keep it up there. I'm going to throw mine on the ground. So you can operate on it. You can radiate it. Those are called local control treatments. And then when we're talking about preventing recurrences, you can radiate the spot where it came from. You can give them hormonal therapy, or you can give them chemotherapy. So that's the armamentarium, right? Targeted therapy, radiation, chemotherapy after you've done the lumpectomy. Now, So that's the analogy I just gave you. You can whack them over the head, drag them out in the yard, do all of them. Well, that's exactly what they're doing for your wife. Is she's got a cancer that, because it's estrogen receptor positive, is hormonally sensitive. Because it's HER2 new or antibody positive, it is sensitive to this targeted antibody therapy. Human antibody doesn't have squat for any sort of toxicity. It is 2 centimeters. Anything bigger than 1, they're going to get some kind of chemo. So that's why she's getting the chemo, and they preserved her breast. So she didn't lose her breast. She had a lumpectomy. And once you do a lumpectomy, remember, that's equal to a mastectomy in long-term local control if you give the radiation. So your wife is getting the best of care. She's got, don't worry about the insurance. All those things are covered even by Medicaid and Medicare. So your wife has the right treatment. She's had the right presentation to a combined modality treatment group. And she's in that 10% of patients, it's only 10, where every modality of treatment of cancer, targeted therapy, hormonal therapy, chemotherapy, surgery, and radiation are appropriate. So she's a very lucky woman.
You reminded me of the lady that went to the drugstore and she asked the pharmacist for some arsenic. And the pharmacist, I can't give you arsenic. What do you want that for? She goes, for my husband. And he goes, I can't give you arsenic. And she says, well, look at this. And so she hands the guy a picture. And the pictures of her husband in bed with the pharmacist's wife. And he says, well, geez, I didn't know you had a prescription.
All right. Folks, I try. I try.
All right.
Okay, so the news of the week, sir.
Well, wait a minute now. It's your turn now.
My turn for what?
Well, because I sent you the news of the week because I wanted you to have a comment to make, because the news of the week, which is I must be sitting over there. The news of the week is, let me look down. I have my news of the week, 'cause I had it all out here for Ray Tidman too. The top thing in the news of the week this week was salmonella infection
outbreak doubles.
has reached. There you go. Okay,
29 states.
29 states. Well, you people have been with us for 5 years.
Right.
We used to be talking about romaine lettuce, chipotle. I mean, that was back when we were worried about the Zika virus and we were worried about romaine lettuce.
Seems like it was just yesterday we were talking about mosquitoes. And water puddles
in your tires and things. I mean, really.
Turn over your bird bath. Seemed like it was just yesterday.
Well, that brings me to what the thing I wanted to ask that we do going forward.
What's that?
We stopped talking about COVID.
I don't think you can do that, and I am going to tell you that the questions that I get, I only focus on the cancer questions because your turn.
Because we have a cancer sponsor. Who's our sponsor?
Wait a minute. Now go ahead.
Georgia Cancer Specialist, Northside Cancer Center.
All right, so we didn't want to forget that. So we focus on the cancer questions. I have to tell you, I get 15 or 20 questions a week that would not be appropriate, some of them, and then we do get a lot of questions about the boosters and so forth, about COVID, and I try to answer those and do so offline and not here, but we're going to talk about that with the news here again in just a minute anyway. So, but it's very much, I like the fact that the number one thing was people were worried about the salmonella, and I may show you a reason why that is in just a minute. But the third one down was a Ray Tidman one. And it might have been yours. Was that the one about the intermittent fasting?
No.
Well, it's down here, sir. There you go, right there. Intermittent fasting can cut your risk of diabetes and heart disease. So here is a guy who would be a candidate for the intermittent fasting. I'm not trying to sell the keto diet or the intermittent fast or anything else, but the point is that they're linking weight control and dieting to heart disease and diabetes. Now, you remember we were discussing the Mediterranean diet 4 years ago.
Yes.
Remember that? So what's Mediterranean diet? So go to Italy or Greece or somewhere and stay a week and you're gonna see you don't see that many people with coronary disease in their 80s over there if they died before. So, but
When I saw that headline, I thought it's an interesting headline. When you think about a lot of spiritual practices involve fasting,
yeah.
and of course in our primitive lives, there are a lot of times you went without food, so it was kind of a forced fast. So there may be a real survival thing that because a lot of biblical things, there's a health aspect to it, and it's just woven into it that it's not obvious, but it's there. So, diets are a multi-billion-dollar industry. So I don't even want to go there.
Yeah.
But fasting and being disciplined about your life is certainly a healthy thing.
Well, there was a book written in the 80s called The Paleolithic Prescription, and the author was Stanley Boyd Eaton, who happened to be my founding group's son-in-law and was a very famous radiologist. And that book was the book about that ultimately came to be called the caveman diet, and it was translated into about 80 languages, and Boyd became quite famous by it. But the issue is really this: genetic change takes 100 generations. Sort of go back to Darwinian things, and so our bodies that we're in today are hunter-gatherer bodies, where 80% of the time was spent grabbling around looking for a rabbit to hit in the head with a rock and eating stuff that was growing in the weeds.
Carnivores.
Well, that's you had a whole lot of vegetable stuff that you ate was leaves and tubers and roots, and then if you could kill something that had protein in it that was an animal, you did so. But the point was, you were spending all of your time in physical activity, hunting and searching for something to eat. And there wasn't any obesity, there wasn't any fat, there wasn't any animal husbandry, there wasn't much in the way, there was no sugar or anything. And so this body that we got today is eating a diet that it wasn't programmed to eat.
Well, not only that, this body was as you pointed out, was 5,000 calorie a day body. The pioneers and the settlers, they had to consume 5,000 calories a day.
Yeah, but that's not the hunter gatherers.
No, I'm talking. Yeah, I'm just talking about what 20 generations back,
yeah,
or even not even that. So.
But
we're still very
back.
Sedentary. I mean, way sedentary compared to our bodies.
Well, when my dad was in the FBI and I was a boy, we didn't have a car.
Yeah.
Dad had an FBI car, but we couldn't ride in it. So we lived about 10 blocks from Peachtree Road, where you went to catch a trolley, and the trolley was cost some money. So if you got to Peachtree Road, literally, if we were going to Buckhead, which was 4 miles, you walked both ways. As a kid, and I walked to school each way. It was uphill each way. It was so every day.
We're talking about being old now. When I moved here, I took care of one of the oldest people in Georgia. She was 114 years old when she died, and her daughter took care of her. And her daughter studied school by candlelight, and her daughter could remember the first car that came into Fannin County. So, I mean, that's how compressed history is.
Yeah, that's right. So. Yeah, but then when they didn't have cell phones. All right. The next thing that we're going to do is, I hate to do this to you, but how many deaths have there been from the COVID virus? Well, you're reading over my notes.
Don't put the notes out
how
there.
How many were there?
I've never cheated on a test in school.
Okay, how many were there on the July the 1st? That was the 72. Then the next week
74.
Was 74.
So the 98.
98. How many were there last week?
92.
92. You got it. Now. Here's the thing. Well, if you're going to cheat, you might as well just look there. What's this say here?
7.5.
Now, what's that 7.5? What does that mean?
That's the
positive rate of tests this week. So I told you last week.
Not long ago it was 18, and then it was not long before that it was down to 1.5.
It was 1.5 the week of July the 4th.
Right.
So now it's that 3 months. July 4th is 8 weeks ago roughly.
Right.
August, September. No, it's 12 weeks ago. So I told you last week that the thing had gotten down to 11, and that the death rate, the hospitalization rate was going to go down. The death rate's still on its way up because each is lagging the other. But you remember when it was 14 and 18% way back when, they said when it finally gets to what percentage is it, you can quit worried about it. It was 5, remember?
Right.
Well, this thing has gone from 19 or 20 to 7.5 in 2.5 weeks. It's going to be 5 next week. And it gets us back to that point. We said all along, there's not any reason for my grandson, who's a wrestler, to not be able to shake hands after a wrestling match. And they need to let people go on. Now, I think you told me last week that all the games were played. Is that true?
Last week, but we have one canceled out in Western North Carolina
This week?
tonight. Yeah.
Oh, my
we have
God.
one canceled.
For what reason?
Due to COVID protocols. That's what they put on. That's all they said.
Okay, now next.
Due to COVID protocols.
Okay, next was, you're there and you got a camera. What was the stadium seating like? Because I watched that Arkansas game last week in Arkansas, and there wasn't an empty seat in the house.
In high school, they're coming out. I mean, every Fannin, Union, we broadcast, our sports department broadcast up here in Union and Murphy, and I tell you what, the stands were packed. I mean, the stands were packed.
Were they using that buck word in the Arkansas game? All right. So listen, I want to jump to stop talking about COVID.
Now, I've got a question.
I'm going to lobby you this. I'm going to lobby both of you on this.
Wait a minute. Can I ask?
Yeah.
Let me ask
this. Is there a
this.
COVID question?
No, let me ask this, and then I'll get out of the way.
Is
So
that
I'll
the
let
Georgia
Sid make
Arkansas game?
No.
Oh, excuse me.
There's nothing I can do with the two of you today. I tell you, both of you.
We're just stepping all over.
Yes. Now, focus a
That
minute.
new shirt.
Focus a minute.
At Northside Cancer Center.
Yes, focus a minute. You said, and I'm gonna ask you this, and then ask you and get out. You said, how about this? We stop talking about COVID.
Yeah.
Wait a minute. And you said we can't. Wait a minute. So, I agree with both of you. So, why do you feel this way, and why can't we stop? So, I'll start with you first.
Okay. Let me make my point. I, as a physician, cannot trust the numbers I see coming at me. Okay, it's a global statement. COVID is a infectious disease spread by respiratory droplets of the elderly. Okay, that's the group it's taken out. 4% of those in the elderly high-risk population die from it when they get infected. Okay, so that's 4%, but it's a big number for the elderly. It's not a disease of the young people, and we have to get on with our life. We have to plant our crops. We have to earn our money. We have to learn in school. We have to socialize. Okay, the disease that I think we're fighting now is the disease of tyrants. People that want to control us, people that want to keep us afraid, people that are messing with society at some grand level. Now, I'm not a conspiracist person, but I do know that in this country we have just a massive amount of oppression going on that's antithetical to we as Americans, us as Americans. And I think the bigger disease that we need to be facing now is our mental health, our exercise of our personal liberties, our exercise of being humans. And so I would plead with folks to push COVID into just another disease that physicians now can treat,
Yes. Okay.
can vaccinate against, and can deal with. Life needs to go on. So I would like it to be salmonella or flu or anything else, just a disease that doctors talk about and you go to them and you get treated for it.
Okay, so you say we can't stop talking. Now, I agree with both of you. So let me ask you, why can we not stop talking about it? What do we need to continue to discuss?
I think it's largely what he said, and that is that there is so much misinformation and so much internet conspiracy, clearly not in concert with what we know about science about all of this. For example, that the vaccines got particles in it that were sent in there to try and sterilize females so that we had population control, or that Bill Gates has put nanoparticles in there so they'll know where you're going. I mean, it's not really funny, because sizable group of people that believe that sort of stuff. It's up to us to say these vaccines are out there. They're on a emergency use protocol, that they're going to sooner or later be released, and that where you've got huge amounts of people that are fine China, they ought to be immunized, and it's going to help protect them. I'm not going to try and tell anybody that they need to get their kids or their young adults immunized. Some places they're going to have to work. So if you work for Delta and you want to keep flying, you're going to have to get immunized or pay $200 a month for the privilege of not doing it. I don't believe that either. But the point is that we need to give them a reliable scientific information when there is information out there that's incorrect. And Ray's right, I'm right. I've kept saying my grandson who wrestles ought to be able to shake hands, and the guy that plays rugby ought to be able to shake hands, and that they
ought to be playing rugby and wrestling.
And the boys ought to be able to play football. That's the point. I
don't disagree with
that's
both
where
of you.
That's where the political, psychosocial, controlling things are getting in the way of science. But on the science side, that vaccine out there is going to help. And let's go say this. Now, there are a significant number of deaths in people who have been younger. And they just published about an 18-year-old girl and her teacher who died. Well, I happened to be able to see a photograph. That 18-year-old girl weighed 300 pounds. And the teacher weighed 300 pounds. And so the teacher was about 50 and the girl was about 18. So it's a tragedy that an 18-year-old died. But if an 18-year-old dies, it's generally going to be obese, somebody who has asthma or chronic lung disease, and not a kid who's in the band or cheerleading or just a regular high school kid.
And it has gone to crazy levels. I mean, you have in Australia 2 deaths, and they've extended martial law and have locked that whole part of the country down. Now those 2 deaths are tragic. But people die. Ain't none of us getting out of this alive. Why can they shut down? I'm certain of it. I'm really.
Well, let me say this because I listen to both of you, and not that you don't say it, but you know what you don't say anymore? When we used to close, and I have not gotten one.
What about donate blood?
No, relax. I have not gotten one, but the stigma, as I would say, and I've thought about getting it, is not right. You never look at the camera anymore and say, go get your flu shot. Or you know what you don't say when we close? Go get your shingles shot. Remember that used to be our closer? Go get your shingles shot. Now, I haven't had one, but I thought about
shingles shot.
You
better go get the shingles shot.
Well, I thought about going and getting the shingles shot. But at the same time, 50? If you don't stop. At the same time, I'm thinking about going to get the shingles shot. Guess what's not surrounding that? This crazy spin around the shingles shot to where it hasn't scared me away. But right now, disinformation, information, bad information, no information. Because this is like you. Let me ask you this. You said
you'll be 50 next year. So
49 and a half for a long time. We're at 7.5, right?
Yeah.
Do you know how you get down to you said you don't worry about it under 5. You know how you do that? Just stop testing. Nobody tests at all anymore. Just throw caution to the wind. No more testing. Guess what? There's no more positivity rate.
Testing a whole lot less than they used to.
Now, don't take that wrong, but that's where we're at, I think, with this on the confusion level.
On the other side, though, the point is, if you want to get on an airplane to Italy, you got to be tested. If you want to go in and get a colonoscopy, you got to be tested. So the point is, they're going to have to be. You could not get tested, but you can't get your colonoscopy. Now we want you to have your colonoscopy to detect your cancer. Yeah.
Let me ask you a question. In all due respect to both of you gentlemen here in our community, and you guys are important folks. I know we have people watch all around the world this segment, but you guys are important to our little community here. Most everybody in town knows the two of you. You have said since day one, or when it came out, get your vaccine. You go get your vaccine. You've not discouraged that in any way whatsoever.
No.
Okay, and I have no problem with that. But what they did to it out there, and what they confused the world with out there, I can't. I can't understand where we got from go get your vaccine to where if you don't get a vaccine,
That's the mental health part I'm talking about. Because it's not logical, it's not scientific.
Let me say this, and I
yeah,
want to close with my guest over here. But you guys, if you got other things, yesterday, I think it was yesterday, in one of the committee hearings in Washington D.C. That real brain trust up there that we've put together in D.C. One of the committee hearings, you know what one of the committee hearings was about? It was about Facebook, which owns Instagram, and it was about Instagram's effect on young women.
Oh yeah, no,
Right?
about damaging the self-esteem of young
Self-esteem,
girls.
right?
Yeah,
Now, right?
It's hard to be.
Wait a minute. But that's what it was, right?
Yeah.
I was working. I hate to tell you.
No, but what I'm saying, when have we had that same panel talk and discuss about the effects of what this has done to our kids?
Yeah.
Have you heard that panel
No,
yet?
I haven't heard that panel.
Right?
No.
That's all I'm saying. You got to take the time, which is okay. I'm concerned about kids' self-esteem. Look, I know this. I know this for a fact. Let's just say I have some young nieces and nephews. You have college students now telling the professor, "Oh, I can't take the test. I've got the COVID."
Yeah.
Right? Or I don't feel good. I might have COVID.
What a great excuse, huh?
You have
That's a lot better than a dog ate my homework.
right? I'm just saying. So, what have we not discussed with COVID that people do ask you weekly that you think we really need to be serious here and talk to the audience?
It's the booster issue that comes up all the time. I am telling my patients who have stage 0 chronic lymphocytic leukemia, which we treat by watchful observation, monoclonal gammopathy of uncertain significance. We observe those. Those are immune suppressed people. They need to get the shot and the booster. People who have had chemotherapy, people who've had bone marrow transplant, all those patients, they not only need the basic shots, but they need the booster because of the huge amount of death they're going to have. Now, when they say that the booster hasn't been approved yet for Moderna, for example, it's not a new shot. Everybody thinks it's a new shot. It's just the same shot 6 months later. And I haven't suggested that anybody outside the obese, the elderly, or the immune suppressed go worry about the booster. I don't think we know much about it. I mean, I've told my childbearing age patients who aren't nurses or flying for Delta that have to have the shot, I wouldn't take that shot if you're still thinking about having kids. I wouldn't take the first set of shots. Yeah. Now, Steve thinks I'm a nut for that, but I believe that a healthy woman in her 20s, 30s, and even low 40s who still has the ability to parent and still thinks she might want to be a mother, that the chances that she's going to die of the COVID are so low that I would not take the shot.
I would not risk my fertility.
Well, not fertility. You don't know what.
The shot could risk her fertility versus a disease that's not likely to take her
or
out.
what it might do to an unborn child that if she's pregnant when she gets it.
Yeah.
Remember now, pregnant women are excluded from all research. Right. So this study has not been done on pregnant women.
And won't be.
And won't be done on pregnant women. But I just read the other day that it's, quote, safe for pregnant women theoretically. But I'm just going to tell you, I believe pregnant women are a special group of people. Yeah. God believes, excuse me, I'm not going to get into that. The unborn child is a special thing to me. The most vulnerable period is time of conception to 12 weeks, and you don't know you're pregnant yet. Yeah. So if you're in the childbearing years and you're thinking about getting pregnant, enough said.
Okay.
Planned Parenthood doesn't want to hear me.
Did you like my joke? I thought that arsenic was good.
I thought it was great. I didn't know you had a prescription.
I can only come up with one a day.
That's it.
So anyway,
you're going to stop there.
Okay. Yeah. And I'm not telling you to get your flu shot yet.
Not yet.
Not yet. No.
Shingle shot.
Shingle shot. If you want to have the shingles, it's a mess.
It's
if you
painful.
Don't want to have
it's painful.
You don't. I've had the shingles 3 times, long before the shingle shot came out. But I had the shingles shot also, because I don't want to have it the 4th time.
Thank you, Georgia Cancer Specialist, affiliated with Northside Cancer Center. Thank you, Dr. William Whaley, Raymond Tidman, and we're going to take a break, and we're going to come back, maybe explore some of these things in a different direction with our all-star political panel. Take a break.